DNB theory question, which is 10 marks question from December 2025 examination, discuss the normal flora of the skin with regards to specific sites. So this is going to be discussed in this particular video. Watch it till the end. You are also going to get the important points related to terms of the basic of normal flora of the skin, all covered in this video. Hello dear students, myself Dr. Maddineni Srinivas, your dermatology faculty from Bharat. So let us begin the discussion without any further delay. So first, coming to the introduction on the genomic classification. The human skin is very complex, dynamic, and it is contagious barrier interface that separates the internal physiologic environment from the external environment, right? Rather than being sterile, you may be thinking that skin will not have any microorganisms and it is very sterile, but the healthy skin actually has millions and millions of other organisms, right? And these are all put together called as skin microbiome or microbiota. Traditionally, it was studied via the culture methods, but ultimately we now are using some targeted methods which are very highly sophisticated, that is 16S RNA gene for the bacterial identification and the ITS1 region for the fungal identification, right? And broadly you can remember these as Actinobacteria, Firmicutes, Bacteroidetes and Proteobacteria. Now coming to the ecological definitions of the cutaneous microflora. So before understanding the regional site-specific organisms, you should also know these important terms related to these microbiota. So what are commensals, what are symbionts and what are pathogens? So briefly, broadly, you can understand the commensals are the organisms which are forming the majority of the microorganisms over the skin, and they are present over the host, and they are going to take up some benefits from the host, but they do not have a direct benefit to the host. So host will not get any kind of a benefit from the commensals. Examples are Staphylococcus hominis, Staphylococcus capitis on dry body sites, Corynebacterium species in the moist intertriginous folds. So this is about the commensals. Next is symbionts. So these are going to have mutual beneficial or symbiotic relationship with the host, the person whoever they are living on, and basically they actively participate in barrier homeostasis, and also they train and prime the cutaneous immune system of the individual, and they are also going to exclude the foreign pathogens. So there are various mechanisms by which they can exclude or they can kill the foreign pathogens, right? We are going to see that one by one. Example is Staphylococcus epidermidis through the AMPs which it produces, and also the lactobacillus because of the fermentation of the glycogen into lactic acid, leading to the acidic pH of the vagina, right? So these are the examples for symbionts. Now pathogens, what are pathogens? Obviously they are going to cause structural damage, and you all know what are all the important pathogens: Staphylococcus aureus, Mycobacterium leprae, and certain zoophilic dermatophytes, right? These are all the ones which you need to remember. But what happens is, very interestingly, the commensals and also sometimes the symbionts like Staphylococcus epidermidis, they are very versatile, and strictly speaking they do not cause any infections in the host in whom they are living. But if there is some problem in the barrier function, if it is breached, then they are going to become the opportunistic pathogens. So just you can imagine, and synonymous or analogous to this Kattappa who is killing the Bahubali in this movie. He was very much mutual friend, or we can say he was also a warrior who was a slave in the kingdom, but he is working under Bahubali. But unfortunately, because of the change in the situations, he ultimately killed Bahubali. Okay, so likewise here also the organism Staphylococcus epidermidis, for example, it is actually a symbiont, which is sometimes because of the breach in the epidermal barrier is going to cause infections in the host, right? Now coming to the mechanisms by which pathogens are killed by the normal skin flora. So there are many of them, like for example the AMP, antimicrobial peptide, the bacteriocin, which is produced by the Staphylococcus epidermidis. This is going to target and kill the Staphylococcus aureus, which is a pathogenic organism. and also nutrient depletion and the toxic metabolites. Like for example, Commensals, they are going to consume the available carbon sources and release the toxic byproducts, that is free fatty acids from the sebum hydrolysis, and this way they are going to block the pathogen adherence to the corneocytes. Next is immune response amplification. So these normal flora, they can stimulate the production of the interferons and the cytokines, which are going to keep the cutaneous innate immune system in play, and they are going to cause the rapid pathogen clearance. So these are some of the mechanisms. Of course, this is again AMP, the lipotecoic acid. Okay, so these AMP is also a separate topic which we are going to discuss in a different video. So we have seen one classification of the organisms into commensals, the symbionts and the pathogens. Now we are going to see different type of classification which is based on the ecological classification of the skin microflora into resident flora, and we can also have the transient flora, and we can have temporary residents. So you should understand what is the slight difference between these three terms. So what are resident flora? So these are the relatively stable and permanent populations which can be seen in few areas of the skin. So these are going to be firmly attached to the stratum corneum, and the population increase occur via multiplication, that is proliferation or colonization, rather than exogenous deposition. So the organisms which are the resident flora, they are going to be staying attached to the skin and they are going to multiply. So what are the examples for this? There are so many of them. Gram positive cocci, that is Staphylococcus epidermidis, hominis, capitis and warneri. Gram positive rods like Corynebacterium, Brevibacterium. Anaerobes like Cutibacterium acnes, which you might have read in your acne topic. Cutibacterium granulosum, Staphylococcus saccharolyticus, right? And we have this Acinetobacter, which is gram-negative bacillus, yeast Malassezia. Not only that, remember there are some transient flora, very interesting, isn't it? So these are free living unattached surface organisms which are derived from exogenous sources, and they cannot multiply. That's why they are called as transient flora, right? They are very transient. Basically these are present in other areas which are getting lodged onto the skin. Like for example, you can have this perioral skin having streptococcus species which are the normal salivary transients. Okay, and also gram negative enteric rods which could be present in the perianal skin, that is Escherichia coli and Pseudomonas aeruginosa, and also the yeast Candida albicans. Coming to temporary residents, so these are associate flora. So these are somewhere they fall somewhere in between the resident flora and the transient flora. So they can colonize and also establish moderate numbers for limited periods. They cannot stay over the skin for long periods of time, right? And they rely on the environmental factors or the metabolic activities of the resident flora to persist. So what are the examples for this? Staphylococcus aureus. It is the clinical point which you have to know related to this is it is carried in the anterior nares. So 30 to 35% of the healthy subjects may also have this, and in the perineum up to 20% of subjects may have the Staphylococcus aureus as a temporary resident or associate flora. And what is the significance of this? If a person is having a recurrent infections due to the bacteria, like for example folliculitis, recurrent furunclosis, so we should also think about this Staphylococcus species which is a temporary resident present in the anterior nares. Okay. So what are the regulators, that is self degerming and homeostatic regulators which are present in the skin? For example, discommission is one of the very characteristic and very normal phenomenon which happens, which is continuous shedding of the corneocytes, because of which the organisms which are attached onto the surface of the stratum corneum, they will be shed off, and there will be self degerming of the organisms. Next is desiccation, that is obviously there is low moisture and humidity in the outermost layers of the skin epidermis, and this will limit the survival and replication of the transient gram negative pathogens. So these gram negative organisms, they can produce the diseases, and because of this desiccation process and also discommission, these organisms will get shed off. Obviously the acid mantle, the organisms are not going to be able to proliferate in the acidic environment. Of course, there are a few of them which can withstand this acidic environment, but most of them cannot. Like for example, direct bacteriostatic effect which can be seen on Staphylococcus aureus and Streptococcus pyogenes is because of this pH, which is 4.5 to 6.2, right? Sebum surface lipids, they are also going to be helpful. Like for example, the Cutibacterium acnes, it's going to digest the sebum and it's going to produce the with the help of bacterial lipase, it's going to produce the free fatty acids, like for example sapinic acid. Okay, and this is having bactericidal effect, so that will prevent any gram positive pathogens to proliferate over the areas which wherever the Cutibacterium acnes is in high concentration. And also the antimicrobial peptide production. So this I have already told you, this we are going to discuss in a separate video, right? And also bacterial interference, like for example Staphylococcus epidermidis, it is going to secrete serine protease that directly is going to inhibit the Staphylococcus aureus, which is obviously a pathogen. Now this is the actual topic of the theory question which you have to write in the examination. So let us begin the discussion. Biogeographical topography of the skin microbiome, right? So what is this? It is basically divided into three major microenvironments which you have to remember. The sites which are rich in the oil, they are going to be the sebaceous sites. So what are the organisms present in these sites, and what are the organisms present in the dry sites, and organisms in the moist sites? So these are the three microenvironments which you have to remember. So let us begin the discussion with the sebaceous or the oily sites. So the organisms which are going to be present here are going to obviously feed on the oil produced from the sebum. And what are the sites which are present, which you have to remember? You can remember above the line joining the nipples. So whatever is there anteriorly and also posteriorly, these are all the sites which are rich in the sebum, or these are all oily sites. So all of them are forehead, scalp, face, alar creases, chest, upper back. So these are all the sebaceous rich sites. Okay, and of course you all know these sebaceous glands, they are holocrine glands, right? So the bacteria which are present in these sites are obviously Cutibacterium acnes and Cutibacterium granulosum. The fungi which are present are, you might be knowing from the P versicolor knowledge, that it is Malassezia species, right? Especially in the head and the face, it is Malassezia restricta, and over the trunk it is Malassezia globosa. Mites, the Demodex follicularum in the follicular infundibulum, and the Demodex brevis in the sebaceous ducts. So I hope, dear students, you are enjoying this video. If so, please do that like button. Also do hype this video so that it will be a motivation for me also to make further videos on a regular basis. Next, coming to the moist sites. So for example, whatever the crural areas are there, like for example axilla, the inguinal crease, inframammary folds, gluteal cleft, toe web spaces, cubital and popliteal fossa. So these are the moist sites because obviously they are the eccrine glands which are going to produce a sweat. So what are the organisms present predominantly in these sets? The corniform rots, the Cornybacterium species, Cornybacterium minutissima. That is the reason why this organism is going to produce the erythrasma in these moist sets precisely. Right? Anaerobic rots, Cutibacterium avidum, gram positive cocci, Staphylococcus species, which are coagulase negative Staphylococcus. Coming to the dry sites, what are these areas which are not having this enough sweat glands and also sebaceous glands? So volar forum, hypothenar eminence, legs and the trunk. So there is low humidity, minimal lipid barrier will be there, and high exposure to the external environment. These are the characteristics which are very clearly seen in the dry sites. So these dry sites are going to have a very different type of organisms because of all these points whichever we have told. The exposure to the environment is going to be predominantly seen here. That's why there is going to be interpersonal variation of organisms in these sites, but other than that you can see Staphylococcus epidermidis and hominis in these sites. Now we are going to see some very site specific organisms which you have to remember, which are going to also have importance clinically in dermatology. For example, nasal vestibule. This is a very moist area and also it is a mucosal cutaneous transition zone, right? So this is going to be having normal resident flora, which are coagulase negative staphylococcus, micrococci, aerobic corniforms. Staphylococcus aureus can be a temporary resident in 35% of the healthy individuals, which I have already seen. And this is the very reason for like I have already told you, recurrent furunculosis. So we are going to treat these areas with intranasal mupirocin with 2% mupirocin for a prolonged period of time, so that we are going to take care of these staphylococcus, which could be a pathogenic organism, right? Next we have this external auditory canal, which is most often occluded with the lipid rich cerumen, which is also acidic. And here we are going to have the again CONS corniforms malassezia species. Transient minor residents could be Proteus species, Escherichia and Neisseria catarrhalis. The acidic cerumen is going to obviously prevent the gram negative organism overgrowth, and loss of this barrier is going to produce the problem, which is otitis externa. This could be seen because of the loss of this cerumen. Coming to the axilla, so axillae we are going to have the occluded intertriginous folds with high density of the glands producing the sweat. And here we can see the staphylococcus, micrococcus and corniforms usually. Cutibacterium avidum is a key moist anaerobic resident in this site, axilla. And usually it is going to be sterile and it is not going to have any odor. But if there is metabolism due to the resident Corynebacteria, more and more if there is a metabolism of this particular sweat, then what will happen, it can produce volatile short chain fatty acids, which could lead to the bad odor, which is also called as clinically bromhidrosis in these patients. Toe clefts, that is specifically the fourth web space, it is high obviously in the glands, because of which there could be this hyperhydration, and if there is additional friction because of this additional occlusion, it can lead to maceration. And there are dense populations of Brevibacterium and also Acinetobacter species and coliforms in this toe web space area. And these Brevibacterium, they are going to synthesis is methane thiol from the sulfur amino acids, which is responsible for the cheesy odor, which can be seen in this particular site. Perineum, groin and the vulva, these are all occluded areas, moist areas. So these are the organisms, micrococci, CONS, coliforms, enterococci from the gut. These can be present near the mucocutaneous transient area. Acinetobacter, Staphylococcus aureus in the perineum, they could be the individuals who can carry these organisms up to 20% of the times. In females, the mucosal surface, it could harbor the lactobacillus, which can cause fermentation of the glycogen produced in the acidic environment, that is the lactic acid, and it is going to inhibit the unnecessary pathogenic organisms from proliferating in that site. In the umbilicus, the invaginated part may harbor as a reservoir the Streptococcus pathogens, which could be responsible for the hospital outbreaks. So we need to be vigilant about this umbilicus area, especially in the newborns. Hair follicles and sebaceous ducts. Remember, dear students, these are going to form up to 25% of the total skin microbiome. Okay, you should have an idea about what could be the organisms. Commonly it is Cutibacterium and also aerobic cocci and Malassezia, Petrosporum ovale. Okay. So these are the sites which you can just remember pictographically. What are the oily sites, as you can see, which are marked the sebaceous sites with the red color, and the moist areas which are marked by this green color, and rest of the other areas are the dry areas. So what will be the difference in the cutaneous flora depending upon the age? So you can see in the neonatal period there is going to be very interestingly high surface pH, right? Here sebum is very transient due to the circulating maternal transplacental hormones. And because of this, what happens, there are two possibilities. If the child is delivered through the normal vaginal delivery, skin can acquire the Lactobacillus prevotella, which are the vaginal flora. And if it is cesarean section, then it's going to be Staphylococcus, Corynebacterium and Cutibacterium species, which are going to be predominantly present over the skin microbiome of this during the neonatal period. In the puberty or adolescence, what happens because of the androgens, there is going to be elevation of the testosterone and the dihydrotestosterone. It can stimulate the enlargement of the sebaceous glands and also sebum production. Ultimately, because of this, what happens is there is massive lipophilic species which will be present in these individuals. That is the reason why the acne is commonly seen in the puberty due to the Cutibacterium acnes, and also malassezia leading to the P. versicolor commonly seen during the puberty or adolescence age group. In the elderly, what is skin change which can be seen, there is going to be thinning of the epidermis and also decreased sebum. Because of this, there will be dryness, okay, and also you can see there is immunosenescence in these elderly individuals. So, because of this decline in the lipophilic organisms, usually we are not going to see any acne in the elderly age group, and also there will be decline in the Cutibacterium acnes in the Malassezia species, and there will be increase in the colonization of the transient entry gram-negative bacilli and streptococci in the elderly age group. What are the important diseases which are associated with dysbiosis? So, let us quickly see one by one. The first one is atopic dermatitis. So, in this condition, there is going to be filaggrin mutation, there is going to be xerosis, and also there is going to be deficient antimicrobial peptides. Because of all this, what happens is there is going to be massive overgrowth of Staphylococcus aureus. The colonization could be anywhere ranging from more than 90% in the lesional skin. So, this could lead to the recurrent infections also associated with the atopic dermatitis patients, because also there is going to be this Th2 mediated inflammation associated in this atopic dermatitis patients. In acne vulgaris, there is going to be follicular hyperkeratosis and also androgen derived sebum overproduction will be seen. Because of this, there will be overproduction of the Cutibacterium acnes, which will produce excessive free fatty acids, which can cause inflammation leading to the acne in different stages, different grades. It could be comedones, papules, pustules, or nodulocystic type of acne. Seborrheic dermatitis, the susceptibility to lipophilic ease in the sebum rich zones is going to be there because of this inflammation, which is over inflammation or overstimulation of the inflammatory system in the seborrheic dermatitis patients, where Malassezia species, which is normal commensal, is going to unnecessarily cause hypersensitivity reaction leading to this inflammation which is seen in seborrheic areas, seborrheic dermatitis. The basic problem here is the fungal lipases are going to remove the lipids which are present in the epidermis, leading to the breach in the skin barrier, which is ultimately leading to the yellow greasy scale formation in the patients. Next, erythrasma. Like I have already told you, the Corynebacterium minutissimum is going to over proliferate because of the excessive warmth and excessive moisture, and also you can see on the wood slump examination the coral red fluorescence in the erythrasma patients. Pitted keratolysis, here the Chytococcus or Micrococcus sedentarius is going to produce the enzymes which are going to cause digestion of the stratum corneum, because of which pits are going to be produced, and these are the sites which are going to have increased sweating, like for example the palms and soles, right. Trichomycosis axillaris, hyperhidrosis in the hairy axillary and pubic sides will allow the adherence of the microcolonies to the hair shaft. So, what are the organism? It is Corynebacterium tenuis and also Corynebacterium propincum. So, these are going to form the granular yellow colored concretions on the axillary hair. So, when can commensal cause harm to the patients or normal individuals? So, if there is any breach in the mechanical barrier, like for example, if there is any abrasion and the organism can directly get dislodged, or it could be going deep into the skin in such circumstances, and also in the atopic dermatitis. So, there could be any reason of the mechanical barrier. Ultimately, the normal commensal is going to now become pathogenic, right? And if the patient is having some immunosuppressive effects due to any medications, like for example most commonly systemic corticosteroids, and other biologics also. These are also going to cause commensal overgrowth. Systemic immunocompromise because of the underlying malignancies or due to HIV. That is the reason when HIV patients are going to have very high chances of all the possible infections. It could be bacterial, viral, fungal, and also it will be very aggressive and very difficult to treat. Extremes of the age, that is neonates and also geriatric patients, because of the immune immaturity and also barrier which is not fully functional, there is going to be the diseases because of the commensals. And also there can be individual genetic vulnerabilities because of loss of mutation. Example, the filaggrin in the ichthyosis and dermatitis. There could be disruption in the protective acid mantle, and also which will ultimately reduce the host defense mechanisms. So all this could lead to the commensals which can produce harmful infections in the host. I hope this video was helpful. If so, please hit that like button and also do subscribe to the channel if you are not yet subscribed. And we are going to cover the theory questions which are asked in various DNB, or we can say state examinations, in my YouTube channel. So if you like this concept, if you want me to continue, please hit that like button, and so that it will give more motivation. And if you want to discuss about these questions or any other thing in dermatology, the links are there in the description. You can click them and you can join them. And if you wish that this material should be given as a PDF, you can type PDF in the comment section. If enough students ask for PDF, I will also share this as a PDF. So thank you so much. We'll meet again in the next video soon with the next theory question. Till then, happy learning dermatology. Bye bye.